It's wonderful to be here and to have an opportunity to talk to you today about what I've been learning. Well, that's what I'm going to focus on in this journey that I've been on in knowledge translation, or really, thank you, the term that I use, not everyone in Canada uses, but evidence-informed decision-making, which is closely related to knowledge translation. So I'm going to talk to you and labeled that a fulfilling journey, because really the work that myself and my colleagues and all the knowledge partners that we've been working with over the last 20 years really has been so rewarding as we've learned together about knowledge translation. And just before I get to this map of Canada and tell you a little bit more about the centers, I usually have told people that I feel like I have, or I mostly tell people, I feel like I have the best job in the world. Because I started out as a public health nurse, learned a lot, then moved on to conducting systematic reviews just as the Cochrane collaboration got up and running in the early 90s. I did some of those reviews and then wondered, who's reading these long, boring documents? And I was pretty young at the time and thought, oh my goodness, I just put my heart and soul into this piece of work. It took me 10 months to do this review, and if nobody reads it, I'm going to be very sad about that. And that kind of led us to do some more work into that. And then I did a bunch of studies evaluating different types of knowledge translation interventions, and then I was handed some money to run a center where I get to put what I learned about knowledge translation into practice with public health professionals. So to me that sounds like a really amazing job. And as my husband and children say, Mommy travels around the world on vacation telling people about what she does. But now, after listening to what Molly is doing here, I think we might be in competition for the best job, as well with you, Una, that we really are so privileged to work closely with knowledge partners to really try to make a difference in the types of programs that are available to the public. So I'll jump quickly to the National Collaborating Centre for Methods and Tools. There are actually 6 of these centres across Canada. We've been up and running for about 10 to 12 years. They kind of rolled us in as this was as these centres were coming into practice. They're funded by our federal government, and they really evolved out of the SARS epidemic. And really, if you're have forgotten what happened there, really Toronto ended up being a hotbed. 44 people died from SARS, and the inquiries into SARS illustrated that our public health sector and community and workforce was ill prepared for SARS when that happened. And one of the things that was illustrated was a lack of capacity to use the available evidence to quickly mobilize in program planning. And hence, a few years later, the development of these centers across the country that focus on, in these respective areas, to help develop capacity amongst the workforce and the field to be able to use the best available evidence in these various areas. And they very purposefully had us allocated across the whole country. We go from coast to coast. On the East Coast in Nova Scotia, we have a National Collaborating Centre related to the determinants of health. We have another one in Quebec that's related to healthy public policy. We're at McMaster in Hamilton, where we do methods and tools related to knowledge translation. In Winnipeg, we have one on infectious diseases, and then 2 on the West Coast, one that's related to environmental health and another on Aboriginal health. And so together, while we all work independently, we also are expected to work very closely together to, across these various domains, ensure that our public health workforce can use the best available evidence in all of these domains as they plan their practice. And my center is a little bit overarching in that we work specifically with public health professionals, but as well with the other NCCs to help make available the resources and tools that exist no matter what the topic is, that folks can use that evidence in practice. And I'll tell you a little bit more about the kinds of tools that are available this afternoon, right before we really have an interactive discussion with you about what your needs are. So today I'm just going to talk a little bit about who I am. Molly, said a few times, how did you get to where you are? We'd like to hear that story. And I guess in retrospect, you can make it look like it was this nice, logical process, but really it hasn't been anything. It wasn't, and it wasn't as planned out as it may appear now. Things just kind of happened. Sometimes right timing, right place, and I think that's a little bit about knowledge translation. I'm going to talk about who I am, what I call evidence-informed decision-making, and then reflect on the lessons that I've learned along the way. And just to know that, not everything has worked. Actually, in fact, I believe I've learned much more from the things that didn't work than the ones that went well. And I suppose if we go back to 1993, maybe I would have looked like this little guy here. This looks a little worried and confused. But actually, I have two photos here. I was looking for photos around symbiosis, because I started thinking very early on in my work in this field that we need to work together. I needed to work with public health professionals, and together we could move forward. And this is an example of one of those symbiotic relationships where two organisms help each other out. This is a mutualism where they both benefit. But, really there's not a lot of interaction going on here. So I might have started my career looking a little bit worried, concerned about what might be happening as we move forward. Didn't really know where things would go. And then eventually looked like this. This is a good example of knowledge brokering. I would be that little shrimp there that's learning from the big fish, my public health professionals. Although that public health professional to me looks a little bit worried. They don't really know what I'm talking about, but they're going to trust me, and I'm going along for the ride. Yesterday I actually spent quite a bit of time looking for a really good photo of 20 years later, what does the photo look like now? I have to say I didn't really find one that really told the picture, so I didn't add one. So we're still here with this work. So if we talk a little bit about the journey that I've had, some random words up here. So OSIN is a study that my colleagues received some funding for. And this was very early days of the Cochrane collaboration. We, within a health unit, within our public health unit, we had received some funding to conduct systematic reviews. And I applied for this research assistant position and was brought on board. And what really interested me about this project was that I was going to be able to now do a systematic review evaluating what I had been doing as a public health nurse. So right out of nursing school, I went into public health, was part of the Healthy Babies, Healthy Children program, where we visited at that time every first time mom with a baby. We did a lot of that work. And I was now invited to be a part of a systematic review evaluating the literature on whether or not that was an effective strategy. And this came at a time when in the province that I live in, we had a chief medical officer of health who very publicly had announced that he wasn't really sure that much of what public health nurses did actually made a significant impact on population health, and was giving notice that if there wasn't evidence that demonstrated that he would be cutting funding to that program. And in fact, about a year later, that is exactly what happened. And I can't say, I was telling Molly this morning, there are some things that happen in a political realm that we could never manipulate in a intervention that causes change to happen. This is one of them. This happened in the early 90s and mobilized the public health community in my province to go looking for the evidence, because we knew what we were doing as public health nurses did have an impact. It just needed to be pulled together and a compelling story told about what impact that was having. So we started doing systematic reviews, and as I said, we then started to wonder, well, is anyone reading these systematic reviews? So we received some funding, which we refer to as the OSIN study, and really, this was really an important piece to the development of my career, in that as the research assistant, I had the opportunity to speak to every manager, director, associate medical officer of health, and medical officer of health in my province, not once, but twice, over a 4-month period. So everybody knew my name by the time that summer was done, because I just kept calling and calling and calling until they would take my call. And I was administering a survey, a telephone survey to them, asking about what did they know about systematic reviews, would they overcome barriers to using evidence in practice, those types of things. So we gained a lot of information in that study, but there were a few things that were left unanswered, which was some decision makers, no matter what, were able to find time to read research evidence and try their best to stay up to date with the evidence in their particular area, and others weren't able to do that. And we didn't really know what factors. There were a few things that came out in terms of some suggestions that if my organization valued it and encouraged me to use it, then they were more likely to use it. If they had some, depending on what their confidence level was in using research. So there were a few things that emerged, but there was a lot that we didn't quite understand. So I decided to keep going, and then did my doctoral studies, and focused on, I went back to the same group of people 2 years later and asked them for more information about their organizations. I started to focus not so much on the individuals, but what's happening in the context of where they work, and are there certain things related to the organization. And certainly we learned there that if the leadership of an organization really strongly encouraged the use of evidence, demonstrated that they valued the use of evidence, modeled it, then these were important indicators. And certainly having confidence in one's ability to distinguish good research from not so good research also played a significant key to that. So I ended my doctoral study, had a postdoc, and then had really an amazing opportunity to keep, with my postdoctoral funding, exploring these issues related to knowledge translation or evidence-informed decision-making. Everything we had done to this point was really quite quantitative in terms of survey types of questionnaires, and I felt like we needed to do a much deeper dive to really understand the concepts. And so from there implemented a number of qualitative studies to really understand what types of information was informing public health decisions. So I conducted a series of interviews, just an open-ended question. Describe to me a program planning decision that you've been involved with in the last 6 months to a year. What type of information did you use, was involved in that decision? Who was involved in that decision? And we did quite a bit of work around trying to understand the decision-making process. We asked questions around, because at that was the time at which evidence-based, whatever medicine, nursing, public health was starting to evolve. I asked, tell me what that means to you. Very interestingly, we would get almost as many different answers to that question as there were people that we interviewed. So there's a problem. We have this term, but everyone defines it slightly differently. So how are we going to know if we get there? So all of that work, we developed some interventions along the way. I started to think about, is there a role for the word here, knowledge broker, or some type of a intermediary that can help bridge the gap between research and knowledge users? At the same time in Canada, we had an organization called the Canadian Health Services Research Foundation that also coined this term, knowledge brokering. This is around 2005. Their definition was that a knowledge broker bridged researchers and policymakers and decision makers and helped them come together to develop relationships so that they could work on developing, co-develop knowledge and evidence together. Mine was a little bit more practical and applied in terms of it wasn't so much bringing the researchers and public health folks together, but actually saying here's a whole body of evidence that already exists related to public health that public health folks know very little about and have trouble accessing. How can we help bring that together? At the same time that I will learn from the public health folks what's missing in the knowledge base and feed that back. Encourage them to develop relationships with researchers as well as myself feeding that back to research funders in Canada. So that led us to do a knowledge broker randomized control trial, very, very early days. And in hindsight, we were nowhere ready to do this trial, but somehow I got lucky, got the funding to do it. But what we learned in that was knowledge translation takes a very long time. Developing relationships with organizations is slow and takes a long time. Change takes a long time. So we really need to be thinking about, this was a 1-year intervention period. We had no chance to really see change happening. Although the qualitative, this RCT, we did do a qualitative component. The qualitative component of this trial demonstrated that we had those who received the knowledge broker intervention were now thinking very differently about their practice and the use of evidence. From there we moved into what's called the PHYSI case study, public health systems intervention. And this was a really interesting project in that at that time our national funder, the Canadian Institutes of Health Research, implemented a funding program. It's similar to one we're going to talk about later this afternoon that you have here, where I needed to have a co-primary investigator with me on this grant that was a decision maker or a knowledge user. In fact, I had 3 co-PIs with me. They were all medical officers of health of 3 different public health departments, and we worked together in an equal partnership to develop this project. They were involved from start to beginning with the design, with the intervention, with the measures, with disseminating the findings. And they also were, as an expectation of this grant, responsible for providing 30% of the funding that was required to implement the project. Prior to these types of competitions in Canada, I mean, this was really something brand new in terms of this expectation that decision makers would participate in the co-creation, but as well as the funding. And this really changed the landscape in Canada of knowledge translation. And I recall in those early days arguing with some of the folks that brought this into being to say, well, public health folks don't have this kind of money. I'm never going to be able to get a study funded because this group doesn't have that kind of money to spend on research projects. And later had to go back and apologize to the folks I had this argument with, because when this became important, really, really important to public health, the money was there to do it. And that's what the goal was all along, is that when we were doing something truly important to the decision maker that they needed to do, then that money and funding was there. And now we run a knowledge broker mentoring program across the country. And so we put out a call about every 2 years. It's just shy of a 2-year training program, very intense program. We work with about 5 or 6 organizations at a time, and we work both at the organizational level to change culture, context, and processes at the same time that we train individuals in skills around using evidence in practice, with the broader goal being when they're done their training, they will be able to act as brokers to others in their organization as we work on organizational change. So if we talk a little bit about the Canadian journey, to put things into context, we start with the Canadian Health Services Research Foundation, and this was a funding body that came into being in 1996 with the inaugural president, Jonathan Lomas, who was already a well-developed researcher in dissemination, which we don't really use that term anymore, but very early studies on knowledge translation. And Jonathan's entire mission in developing the foundation and in the research that was funded was to bring together researchers and policymakers and decision makers as equal partners in developing and co-creating new evidence and knowledge. And this was the first funder in Canada to have this expectation that decision makers would bring the money to the table as part of the process. And then we had, in the year 2000, the development of the Canadian Institutes of Health Research. So we had separate funding bodies in Canada prior to there, and then this brought together 13 institutes that became our major health funder. And one of the main reason I mention CIHR is that, again, this was created by government. The funding is provided by government. It was actually written into legislation about CIHR that one of their mandates was to promote the health of Canadians by ensuring the research that they were funding was implemented into practice. So those words are actually written into formal documents, government documents, that this is something CIHR has to accomplish. We then have another program that was called the Search Program. This was actually done within one of our provinces in Alberta and started around 1997, where this was a really innovative program that brought knowledge users, decision makers to interact with researchers and together work on research projects, and then that knowledge user would come to the university and spend some time there and then run projects and learn how to translate that knowledge back to their organization. And this was followed up with another program called the Extra Program, which is still running in Canada today, where the first organization, the Canadian Health Services Research Foundation, ran this program. They would take the senior executives, so your medical officer of health or associate medical officers of health, your top people would apply for this program. It was a 2-year training program where they would learn about knowledge translation, and so they would be taken out for short periods of time, intensive learning, workshops, things like that, and they would go back to their organization, and their main goal was to implement a large project in implementing something new based on research evidence. Then in 2007, the National Collaborating Centers, with this again, this focus on knowledge translation. Molly's talked about KT Canada. This was funded in 2009 and brought together, I've never seen so many names on a research proposal before, because it was in submitting this grant, I think anyone and everyone who's involved in knowledge translation in Canada was named on this grant. Really created a network of researchers that work together and come together to support research, graduate students, and knowledge translation. And then most recently, we have these new centers evolving starting in 2012 that are a strategy for patient-oriented research with a very large emphasis on knowledge translation. So now we're moving beyond our traditional ideas of knowledge users as being those working in healthcare or policy, and involving the patients as well in terms of identifying what are their needs, what are the outcomes that are important to them, really getting much more engaged in patients as well as decision makers working together in these centers to co-create evidence and then implement that back into practice. So if we think about what is evidence-informed decision-making, that process of distilling and disseminating the best available evidence, but also knowing that its decisions aren't just based on research, they are also informed by the context and experience, and then we're putting all of that together to make the best decisions that we can in health policy and practice. But what are some of the issues that we've learned along the way? Again, evidence. What is evidence? When I ask that to a group of public health professionals, I'll get many different answers as to what constitutes evidence for them. And so we need to have lots of conversations that all the evidence, all the knowledge is important. We might use it at different times, and this knowledge translation isn't about saying some evidence is more important than other evidence. We need everything that we can get our hands on. We just might need different times to use it. And then what does evidence-informed decision-making look like? How will I know we've done it? How will I know someone's done it? How do I measure it? We're still grappling with that. So the PhDs and the postdocs in the room, there's still a big need if you're still looking for something. We need a lot of help in terms of looking for reliable and valid measures to show impact. Certainly my funder is always asking, what's our return on investment? How do we know that money we give you every year is really changing public health decision making in this country? Show me how that works. So these are all issues that we have to deal with in this field. And so when we think about a model, as researchers, we usually like drawing pictures, drawing frameworks, models to guide what we do. So this is what comes to my mind when I think about evidence-informed decision-making or evidence-informed public health, is that it's this very complex combination of knowledge sources. This makes it all look very nice and logical, sort of. All the ovals are the same size, all those kinds of things. That's not at all what it would look like in reality. And this oversimplifies very complex decision making, but it's a great way to have discussion. Once we put something down, now we can discuss and debate, well, what's missing from this? But it gives people quickly, when I put this up, it lets you know, I know that decision making in public health is made up of many different inputs. We've been focusing, my center is focused on the research bubble for the last several years. But it's also about the community health context, the local context, the geography. Canada is a huge country, and we are so different. And what might work in Hamilton, where I'm located, likely won't work in a small, remote northern community in Manitoba or Alberta. So evidence-informed decision-making needs to be flexible enough to take that into account. We also know that community and political preferences and actions are really key. So what might be acceptable in certain areas isn't going to work in another area, and that's okay. We need to know that and deal with that. And our public health resources are different across the country. So we get input from all of these different spheres, and our public health expertise helps figure out how to bring all of that information together, figure out what is the best of all of that information, and then put that together in collaboration with community partners, make decisions on programming. If we put this into motion, on any given decision, these spheres would have different sizes. So actually, very infrequently is the research bubble the input that's going to significantly influence the decision. But it's part of the input. Sometimes it might be the local context that drives decisions. Other times it might be the community or political preferences. Other times it's the resources. So it's always changing. There's absolutely nothing static when it comes to knowledge translation. That's what makes it so challenging and also so rewarding as we work our way through it. What this model also allows is, even though we may have the same research evidence. So let's say we have a recent, very well done best practice guideline that's informed by high quality systematic reviews, meta-analyses, and other types of evidence. If that may remain consistent or constant in various decisions, different localities in Canada may make different decisions about what to implement based on the rest of the inputs into that decision. And that's what we would say really is the essence of evidence-informed decision-making, is figuring out what fits best with your local circumstances. And that actually oftentimes means you're not implementing the most effective intervention, but the one that will work in your setting. And so we work with health units to figure that out. So when I think about knowledge translation, I have a lot of images in my presentation. And when we think about what's going on and how do we measure it, it's a little bit like going to the symphony. Because in the symphony, there's many different roles. There's all these different instruments. They all have a slightly different role to play. Some of them have completely different music that they're playing from the others. They come in at different times. And these are all the moving parts that are happening. What I've learned anyway, over knowledge translation, working with a public health unit to implement evidence, we have all these different players, and we need to figure out how to talk to each of them and how to get them all to make beautiful music together. And we still are working on figuring all of that out many, many years later. So there's lots of challenges. Time. I usually, when I ask public health folks to tell me what their challenges are, I don't let them say time, because time's always been there and time will always be there. So what else is there? But certainly time is a significant issue. It's not that anyone is, and I'm sure it's the same here, anyone sitting around looking for something else to do because we already have way too much on the go. We always have competing priorities. There is always that something really pressing that we need to get to. Does the management really truly support? So in Canada, we now have the luxury of, being at a time when I don't think there's a senior executive that would say knowledge translation or evidence-informed decision-making isn't important. They will all say it's important and we need to do it. But whether or not it truly is supported and modeled, that's where we're doing more work now. I've learned that library services are really, really key. Easy and quick access to the evidence. While only one piece of the puzzle, without it, the battle, it's a really hard battle to actually be able to promote evidence-informed decision-making without it. Not every health unit in Canada has a library or library services or a librarian, and many of the librarians, if you do have one, many of them, they're trained in a way that says, when someone has a question, my job is well done when I find absolutely everything that answers this question, even if that means I'm handing you something that's has 2,000 articles. Or it's easier now that they're not printing everything, but you might get a database that has 2,000 or 3,000 hits, and they are going, great, job well done, and the person over here opens it and then closes it, because how do you even get started with that? We've learned over the years that it's really important for knowledge translation work in public health to not be a make work project. It needs to be real and tangible. So helping them focus on something that's a key issue to the health unit, something they need to make a decision on, is really, really important. We can have limited engagement, and if you're someone who wants to see progress quickly, this might not be the role for you. Or I think my mom knew when I was little I had some patience trouble, so she used to make me stir the white sauce, because that takes like half an hour. You can't stop. Learns patience. It's very, very slow progress, and it's hard to see that you're moving forward, and so you need to adjust your expectations. So what are some of the issues with respect to the evidence-informed framework? Well, we have knowledge, skill, and capacity. So amongst the workforce, Not sure what training is like here in Ireland, but in Canada, we aren't necessarily graduating the public health workforce with the skills and how to do knowledge translation. So we have two issues. Our new graduates that find themselves working in public health may have limited exposure to the skills related to EIDM, and the people working in public health most likely have not had any training in this area. And then what about the organizational context and culture? How do we work with organizations to really change the way they do business? So I'm going to give you a couple of images here around what EIDM, evidence-informed decision-making, what picture I have in my mind and what it requires. So this is, if you're ever in Canada, about 5 hours north of Toronto, Killarney Provincial Park. These are our mountains in Ontario, because we really don't have mountains. These used to be mountains, apparently, a long, long time ago. And there's a 75-kilometer backpacking trail that's really, really hard to do. And I put this image up here. This reminds me of evidence-informed decision-making, primarily because it's a loop. So lots of times there's many different models and frameworks around dissemination, translation, evidence-informed decision-making. Lots of, particularly in the early days, there were these very linear models that took you from this step to this step to this step. And that's really not how I think EIDM goes. This one, and this backpacking loop is a circle. And there's no one right place to start. You can go in either direction. There's different places you can start. And so that says a lot about EIDM. But one of the things that this doesn't remind me of with EIDM is really you're left on your own. You're told, you know, if you're going in there, they say to you, make sure you can do it because we're not going to come in and help you if you decide it's too hard. So this isn't about EIDM because we need to work together. And that took me to this picture where to get folks to the top of Kilimanjaro, you need a whole team. A whole group works together to get you there, and that to me is really, really an important piece of knowledge translation. We need to work with our partners, our community partners, other stakeholders to help achieve our summit. And then this last piece is about trust. So who would have thought going for a walk on a glacier would require you to step on a ladder with a 200-foot drop below you and a guide saying, don't worry, just look at me, walk across. Of course, do all this before you have children. I don't know if I would do it now. But EIDM is a lot about trust. We need to trust in our stakeholders, trust in our partners as we go on a journey together. And not necessarily knowing where we're going to end up. So we want to talk a little bit about EIDM roles and responsibilities, and I do this with public health quite a bit. Everyone has a role to play, and it may be that in any organization you have some people that are involved in the whole component of working on EIDM, but other people may have other roles. We talk about questioning practice. We need to have this healthy dose of always wondering, is there anything else we could or should be doing? Is there anything maybe we shouldn't do anymore and be replacing it with something else? We need to be critical consumers of the evidence and all the knowledge that passes by our screens. We need to continually develop our knowledge and develop new skills around EIDM. We need to be involved in program decisions and bring those innovative ideas. We can be involved in developing new organizational structures that support a decision-making process that includes the evidence in that process. And then what can we do to influence and motivate our peers to become part of this? Can I have a few extra minutes? So there's a couple of different things that might evolve with respect to EIDM, and there's all sorts of different people. And so some people might like this. If you were going somewhere, you want to be able, of course we don't have to do this anymore because now we can have someone just tell us where to go and as we're use our GPSs, but some of us want everything clearly spelt out. Go this way for so many meters, turn right, turn left, tells you exactly how you're going to get there. But sometimes really EIDM is like this, can sort of see where we're going, but not like it's really fuzzy and I'm a bit uncomfortable. I'd really like to see better. Maybe sometimes it's like this, can really see very clearly, but I don't know where I'm supposed to be going. Or this one where I can see where I'm going, but how I'm going to get there is really blocked. And all those types of things can happen, except probably the first one. Like right now, we don't have that recipe for exactly how to achieve EIDM. So for those of us that are most comfortable with that type of working model, then EIDM might be uncomfortable for us in terms of being involved. But we need to have that flexibility to not always know where we're going, but believe that by working together we can achieve it. So just a couple of other things that I've learned along the way. Senior management support amongst the knowledge users that I work with is really, really important, and I work very hard to develop relationships with them. You need internal champions in the organization and at multiple levels, not just in senior management, but throughout. Senior management, middle management, staff, all the levels need to have champions. And some of those are formal champions and others can be informal. We need to communicate a lot and many, many times over and over what our messages are, what we're trying to achieve. We pick priority projects, so it's something the organization needs to make a decision about in the short term, and we work on that. And then we need to be really, really flexible. Working in partnership with our key stakeholders, we need to analyze their interests. So as researchers, and my focus has been to work with public health on what is important to them, not on what's important to me. And then we developed our relationship. Figure out who's supportive of these ideas, who isn't supportive of these ideas, and figure out ways to deal with that and engagement strategies. And so I might just leave you with a few final photos. In my experience in this journey of evidence-informed decision-making, there's been, of course, some people that were really ready for knowledge translation and worked really closely, wanted to be involved right away. Sometimes it's kind of like this, kind of angry, pushing back, what is this, don't really like it, why are you in my space? And then others really, the majority of people have been kind of like this, which is, you could say, our passive aggressive. I'm just going to keep my head down and keep quiet and all of this will go away, hopefully. And we've had to learn how to deal with all of those different types of groups and many others that aren't there. We need strategies when we're talking to our partners to deal with all of these different ones. Finally, keys to success. We need involvement from many different levels, and really, really important to start where folks are at. So I don't go in to work with an organization with preconceived ideas of what they need and where they are. We really assess to say, have them identify what are your strengths, where do you want to go to from here, and how can we best help you do that. And that's that collaborative goal setting that allows you to then come back annually, periodically to assess achievement towards those goals. And then being really flexible, and of course along the way learning from each other. So really I've taken the lead from the organizations I've worked with. I've learned so much from working with the public health departments around knowledge translation, and then taken that knowledge to work with the next health unit and have them again inform how does this fit for us as we test and try things. So I'll stop there. Thank you for your attention.